Melanoma treatment starts with one question. How far is the melanoma grown, and what treatment will remove it completely without losing information needed for staging?
You see, that exact clinical conflict, trying to balance total, complete cancer clearance with the absolute necessity of preserving crucial microscopic data, well, that drives literally every single step of modern melanoma care. We're not talking about a simple one-size-fits-all procedure here.
This explainer was written and edited by Dr. Thomas Hocker, a triple-board certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist. So let's dive straight into the evidence, shall we?
Wait, practically speaking though, how does treating a tiny surface spot on the lower leg actually differ from dealing with, say, a deep 3mm ulcerated tumor right on the back? I mean, they're both melanoma, right?
Right. Well, they definitely share a disease family, but they absolutely do not share a treatment pathway. A small in situ spot is essentially a local margin mapping problem. But that deep ulcerated tumor, that's a local surgery problem, a regional lymph node staging problem, and potentially a systemic treatment problem all wrapped into one.
To really understand this, it helps to think of melanoma care kind of like planning a trip using 3 completely distinct maps. You just can't force every patient onto the exact same road. The first map, that shows the edge of the original local tumor based on pathology. Map 2 shows the regional lymphatic route. And the third map, that covers the rest of the body for systemic therapy. Excellent care means pulling out the specific map that matches the exact question you're answering at that moment.
So, our first map starts right at the pathology report, and we really need to clearly define in plain English what it is we're looking at. Melanoma in situ basically means the cancer is totally confined to the epidermis. That's the very outer layer of skin. It doesn't have direct access to deeper lymphatics or blood vessels, so we treat it strictly as a local margin problem. Invasive melanoma, on the other hand, has broken through. It's entered the deeper dermis, and once it's invasive, we absolutely have to measure its depth because that single measurement completely changes the entire surgical and systemic strategy. Which brings us directly to the crucial features of that pathology report. Now, the absolute most critical one is Breslow thickness. We're not talking about how wide the spot looks on the surface of the skin. This is a microscopic measurement from the very top of the skin down to the absolute deepest invasive melanoma cell. Next up is ulceration. This just means the epithelium over the tumor is biologically absent, which instantly raises the staging category. And then you have features like microsatellites. Those are separate microscopic deposits nearby, and finding those instantly shifts a patient right into a regional stage. Every single one of these details changes the surgical game plan.
Because surgery is usually the very first step for localized melanoma. Those exact pathology details dictate our clinical margins. For melanoma in situ, guidelines recommend taking a 0.5 to 1 centimeter margin of normal appearing skin. For invasive tumors up to 1 millimeter deep, it's a 1 centimeter margin. If it's 1 to 2 millimeters, you're looking at 1 to 2 centimeters. And for melanomas over 2 millimeters deep, the standard guideline is a 2 centimeter margin.
Hold on a second. If a melanoma is thick and aggressive, wouldn't cutting more skin always be safer? Why in the world would you stop at just a 2 centimeter margin?
It's a great question, but precision is a fundamental cancer principle, not just a cosmetic preference. A huge multi-center randomized trial actually looked at this exact question for thick melanomas. They compared a 4 centimeter margin straight up against a 2 centimeter margin. And after nearly 20 years of follow-up, the hazard ratio was 0.95. There was essentially zero survival advantage to routinely removing a massive 4 centimeter circle of skin. So wider is absolutely not automatically better.
But anatomy and context matter tremendously here. Just look at what happens on complex, really tissue-sensitive areas like the face. In a 10-year series looking at head and neck melanoma in situ, taking a standard 5 millimeter margin only cleared the cancer 62% of the time. Think about that. To actually reach a 97% clearance rate, surgeons had to map out up to 15 millimeters. You literally cannot just guess a giant uniform circle on someone's eyelid or nose. You need a completely different strategy.
And that strategy is Mohs micrographic surgery or staged excision. Standard wide local excision relies on a pre-planned clinical margin that's removed in one single operation. Mohs is entirely different. It is careful, iterative cartography. It traces the true, actual microscopic edge of the cancer, stopping precisely where the tissue is healthy.
This ensures complete margin assessment while preserving normal skin, which is exactly why it's so incredibly compelling for poorly defined lesions on the head, neck, hands, or feet.
Now, it's super important to understand that using Mohs for melanoma is not the same simple procedure used for basic basal cell skin cancers. It requires deep, melanoma-specific expertise. The team literally has to use specific immunostains, like MART1, SOX10, or PRAME, just to make these really difficult-to-see melanocytes visible under the microscope. And even more crucially, the central tumor must be sent out for permanent section pathology. This guarantees that definitive breast load depth, ulceration status, and all that vital staging data are never destroyed or lost during the surgery.
When this is done correctly, the local recurrence data is honestly striking. In a cohort of 662 melanomas in situ, followed for a median of 8.6 years, the recurrence rate after Mohs was just 1.8%. Compare that to standard wide local excision, where it was 5.7%. For hard-to-see or poorly defined melanomas, iterative mapping drastically reduces the chance of the cancer ever coming back in that same spot.
And preserving that healthy tissue does not mean trading away survival. Massive adjusted registry data backs this right up. In a National Cancer Database analysis of stage I invasive melanoma, Mohs was actually associated with better overall survival than wide local excision, showing a hazard ratio of 0.86 over follow-ups extending to 10 years. Now, while this is observational and it doesn't prove that Mohs alone caused the survival bump, it proves absolutely decisively that tissue preservation with Mohs is oncologically sound.
Okay, let's step back for a second. We've got the primary tumor on the skin, completely mapped out and cleared. But what happens next? What about the lymph nodes? Well, that brings us exactly to the second map of melanoma, the regional lymphatic root.
We evaluate this map using a sentinel lymph node biopsy, or SLNB for short. The absolutely crucial point to remember here is that this is purely a staging procedure to gather information. It is not meant to cure the patient by itself. It is simply looking for microscopic regional disease. And because it does carry real surgical risks, it is not an automatic requirement for everyone. In fact, it's specifically not recommended for uncomplicated, thin T1A melanomas under 0.8 millimeters without ulceration. We only really discuss it as the depth and the adverse features start to rise. But if a sentinel node actually comes back positive, don't you just have to go back in and remove all the remaining nodes in that area just to be safe? We definitely used to think so, but the MSLTII2 randomized trial proved otherwise. They compared immediate removal of all remaining nodes directly against simply watching the basin with active ultrasound observation. And the melanoma-specific survival? Exactly identical. 86% versus 86%. But the radical surgery caused massive permanent limb swelling called lymphedema in 24.1% of patients compared to just 6.3% in the observation group. So a positive node is vital staging information, but it's not an automatic mandate to blindly remove every remaining node. Once we have that solid staging information, we can open our third map, systemic therapy. And for certain high-risk stages, modern medicine has completely flipped the traditional timeline. The NADINA trial looked at resectable macroscopic stage 3 melanoma by using a neoadjuvant strategy, meaning they gave combination drug therapies before ever performing the surgery. They achieved a massive 83.7% event-free survival at 12 months. That massively outperformed the old standard of operating first and giving drugs later. Beyond those neoadjuvant approaches, systemic drugs given after surgery, which is called adjuvant therapy, seek out microscopic disease hiding anywhere in the whole body. These can significantly reduce recurrence for resected stage 2B all the way through stage 4 melanoma. The exact drug depends heavily on multidisciplinary factors, like whether the tumor happens to have specific BRAF mutations. And, these drugs require immense care. For example, immune checkpoint therapies rev up the immune system so intensely that they can literally trigger the severe rejection of transplanted organs. That demands some extremely precise coordination with transplant teams.
So, what's the real bottom line here? Because it sounds like excellent care isn't just about maximizing surgery and testing across the board.
Exactly. Decisive melanoma care actually means knowing when not to escalate. If you have a small, well-defined melanoma in situ on a totally forgiving site, standard excision is perfectly fine. We don't do routine sentinel node biopsies for thin, non-ulcerated melanomas. We don't routinely gut entire lymph node basins for just one positive node. And we certainly don't do routine body scans for asymptomatic early-stage patients because, honestly, it causes more harm than good. excellent care is really about treating the actual proven risk completely. Nothing more, nothing less.
Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. We strongly encourage you to take this evidence and discuss your exact pathology directly with your treating clinical team.
So, the very next time you sit in a clinic reviewing a pathology report, look at the evidence and ask this one vital question. Is my melanoma primarily a margin mapping problem, a regional lymph node staging problem, or a systemic treatment problem? Knowing exactly which map you're reading is the very first step toward a cure.